Well, John, Kim said that 4:30 was the best time for you to talk. I guess we're close. We're getting close to 4:30. I wanted to introduce you because obviously you're new to the state. And there's Dr. Ellis. Very good. So everybody's here. So we're going to meet today to talk about autism. And those of us who see patients with autism in the state of Georgia have realized that it's one thing to make the diagnosis. It's another thing to access services. And now, even though we do have an autism law that has helped with access to ABA services, it's still a challenge. And like I saw someone, a 10-year-old the other day, they've been waiting for 2 years to get into ABA therapy. So we all know that that's not acceptable. We've got to see what's working and what's not working. Hopefully, with this session, we'll know, we'll get an idea about, I know there's some good people doing great work. And so I just want to find out how we can make the situation better. Another thing that's been a challenge, and we're not going to address this today, but we all know that when children with autism present to the emergency room, they languish there for days because there's very few facilities within the state of Georgia who are willing to accept them. So that's a problem that I think will need to be addressed, but I don't think we're going to fix that today. But so let's get started. Let's see what time. It's about 4:14. So I want to introduce some of our speakers. I don't know all of you, so I can introduce Dr. Constantino. He is the new Chief of Behavioral Health at Emory and Children's Healthcare of Atlanta. Actually, I guess it's Children's Healthcare of Atlanta, and you have an appointment at Emory.
Correct.
And so, John, I've known John's work for years, and he's done a lot of work in the field. And I know this was a passion of his, and so I'm happy to have him here in the state. So that we always need reinforcements. So this is really good. And then Dr. Michael Ellis is one of my former trainees, and he is the author of a book called Parenting Autism. So. So we're really happy to have both of you here, and also our speakers, Sunita from the Autism she's the Autism and Developmental Disabilities Program Manager at the Georgia Department of Public Health. So we're happy to have you here, and then Malia, the Autism Project Manager, also from the Department of Behavioral Health and Developmental Disabilities. So this should be a meaningful meeting, and my friend Bhavini Solanki, who is the director of behavioral health at Amerigroup. I've worked with her for years, so she's a lot of really great people here. So I hope we can learn from each other. Dr. Ellis, would you mind getting us started? Okay, you're muted. Remember that.
Yeah, sure. Yeah, I'll be happy to get started.
Thank you.
So I'm just pulling up my screen. Can you see my screen?
No.
Okay. Let's see. How can we do that?
Let's see. There's usually a link button to push.
Yeah, I think you have to push something. I think.
At the bottom of your screen, do you see where it says share screen? It's a green button and it has an arrow in the middle.
Oh, there we go. Got it.
Yes.
Okay. Okay. Give me 1 second as I pull it up. Okay, can you see my screen now?
Yes.
Okay. Sorry about that. Okay, can you see the title screen?
Yes.
Okay, great. Okay. So of course, what we're talking about right now is autism spectrum disorder in Georgia. And I wanted to talk about problems and solutions. Now, before I get started, like as Dr. Lukowitz, Eric said, I'm a child psychiatrist, adolescent psychiatrist, adult psychiatrist, but I also myself have a child with autism spectrum disorder. So when I'm going over these slides, keep that in mind. I mean, most of the patients that I treat in child psychiatry have autism. So I mostly do treat autism. So sort of an autism expert in Georgia, but also, and an author, but also a parent. So, okay, so next slide. So autism, in my opinion, is more of a kind of a compounding crisis. As you all know, the statistics, I'm sure, in Georgia, 1 in 46 children have autism spectrum disorder per the latest data that we have from 2018. And roughly, it's pretty similar to what the average is in the United States. So of course, it is a true problem. Schools are overwhelmed, especially with the limited IEPs to give, which I'm going to talk about a little bit later. Primary care physicians struggle to diagnose and refer to appropriate specialists, therapists, and providers because of a shortage of providers. There are problems with recognition of diagnosis, availability of providers, therapists, artificial delays in treatment, poor knowledge of resources, and scarcity of resources. Basically, autism is pretty much the entire community has to become involved. It's an entire community problem, a burden, responsibility, however you want to look at it, depending on what the situation is. As I said, I'm a parent of a child with autism. She's 17 years old now. So I've pretty much been run through the gamut of trying to get resources for my child, trying to get a diagnosis, all that sort of thing. So I can speak personally and professionally. But parents are often overwhelmed from even before day one of the diagnosis because they usually knew that there was something wrong, that there was something going on, but they struggled to kind of get people to recognize exactly what it was or to get an official diagnosis. So they're already overwhelmed right when you see them for the first time. As I mentioned before, it's difficult to get the diagnosis, which we're going to talk very specifically about soon. But there's little help and guidance from the community and from even experts on what to do after your child's diagnosed with autism. It's difficult to start the evidence-based treatments, as Eric said, due to unnecessary barriers, which we're going to discuss. Parents are forced to fight for their child constantly, and I definitely feel that emotion all the time. They fight in school to get an IEP. They fight to keep an IEP. They have to struggle to get teachers to follow the IEP. They have wait lists for diagnosis, wait lists for ABA. They have to wait for the Katie Beckett. They have to be on the wait list for the Medicaid waiver once they're finally approved, which is a huge, difficult process in and of itself. And this is if you are educated enough to know what the correct steps are to take. It's still difficult. But this doesn't include managing everyday life and behavior of living with a child or young adult with autism spectrum disorder with tantrums or aggression, irritability. So parents are already kind of feeling like every day is a struggle. So I wanted to kind of organize what my part of the talk was with problems and solutions, trying to give some problems, some solutions, and not just complain about what the problems are. So problem number one, parents are confused and left to fend for themselves after diagnosis. And that's not just my opinion, that's the opinion of most parents of children with autism. So these are some of the solutions that I feel would be very helpful. So we need case managers from Medicaid or commercial insurances to make sure that kids are getting the much needed services to help with roadblocks and not falling through the cracks, which is very, very easy to do. We need more coherent and organized next steps or protocols. And I mean like medical protocols, psychosocial next steps once a child is diagnosed with ASD. Currently, every family has to feel that they have to reinvent the wheel. I definitely felt like that many times, even being in this field. Had to reinvent the wheel in terms of a treatment plan, community resources, with little education or guidance from medical professionals. And of course, the little guidance from medical professionals is not on purpose. It's just, we're busy. We can't hold their hand for 2 hours and talk about everything that's going on and what they're going to go through. So again, this is not necessarily intentional, a lot of these issues, but it's definitely a process issue. So we're left to kind of feel like, here's your diagnosis, good luck. And it's very difficult. We need respite care with trained staff provided by Medicaid or commercial insurances. Even when insurances do offer this, like I have Blue Cross Blue Shield, when they offer it, there's no business to accommodate those needs. People don't know how to do it. You can't just get your random like healthcare nurse to come in. It doesn't work that way. So we know that we know already what most kids with ASD need. So there should be kind of a ready-made plan in each community, not just Georgia, but each community on how to accomplish those needs, what the needs are. So autism is often treated like a surprise by teachers, by healthcare professionals, by community resources, but it's not. And I hear that a lot, even in school. Oh, we've never had a child like this. And of course, there's no way that that's possible. So we shouldn't act like it. We should have kind of plans already in place for this. And then also, autism isn't rare. It's not like it's an infrequent diagnosis. So we should be better trained and prepared. So one big issue is primary care physician training. So primary care physicians struggle to diagnose. Primary care practices, and I'm mainly thinking about pediatricians, but it could be a family practice. They're fast-paced, they have little time to interact with the child closely. One solution is better reimbursement for well child checks, especially around 24 months, recognizing that that's such a critical time period. So hopefully pediatricians can spend more time with those patients. 50% of primary care physicians do not use the MCHAT, which is a standard of care screening form. And this was shown by a study recently. So that's crucial. So obviously a solution would be requiring MCHAT or other screening or diagnostic tools, especially between 18 and 24 months. In other words, it's not voluntary, it's something that has to be done. There's little training among primary care physicians with ASD, and they generally have a low comfort level. So more training for pediatricians is necessary with developmental disorders. Again, they're not uncommon. And if you look at the broader developmental disorders, it's much more common than just autism spectrum disorder. It's about 15%. That's a large percentage. The reflexive instinct when there's a suspicion of autism is to refer to a psychologist among primary care physicians. But there are too few psychologists to meet that need. There's no way that those trained for autism spectrum disorder, that those psychologists could literally diagnose every single child in Georgia. That's just not feasible. But one solution would be loan repayment or increased reimbursement for psychologists with ASD training who are actually doing that work. So my own daughter was not diagnosed by her pediatrician. Again, not complaining, it's just a reality, and this person came highly recommended and she didn't notice it. We had to request speech therapy because she wasn't talking on time, and there were other problems too. But when we took my daughter to her speech therapist, immediately they recognized the autism spectrum. Of course, they weren't officially able to diagnose it, but it goes to show you that the training and experience is crucial. So talking about scarcity of diagnostic resources. So a pediatrician, a primary care physician, such as a family physician, child psychiatrist, pediatric neurologist, developmental pediatrician, obviously all of these people can technically diagnose a child with ASD. The problem is the insurance companies only recognize a psychological evaluation from a psychologist for the purposes of starting and paying for ABA, which of course is a huge problem. This causes a delay of 6 months to a year to start ABA, and that's provided that there's not a wait list for ABA, which in most areas there's a huge wait list. So we're talking about a delay in treatment of years at times, which is not okay. So ABA is the only evidence-based treatment shown to improve the prognosis of ASD. And as we know, early diagnosis and treatment is key. The earlier the diagnosis, the better the prognosis in general. A delay in care equals poorer outcomes and harm caused. So legislation needs to address this to force the insurance companies to come up with another solution. So we have to address this artificial delay. And there's no reasonable reason for this, definitely no medical reason. So ABA, in my opinion, the solution would be to get started with a diagnosis from a primary care physician, pediatrician, child psychiatrist, possibly even a nurse practitioner, while waiting for a psychological evaluation. One option would be allowing a year for this to get officially done, because that's about how long it takes to get done. But the child shouldn't be penalized or have to wait a year or two in order to start ABA therapy. And the other thing is, it's a little bit offensive to physicians that only a psychologist is able to diagnose the autism for purposes of ABA. It doesn't make a whole lot of sense. And then primary care physicians typically refer those suspected of having ASD to psychologists, as we already said. There are relatively few psychiatrists. There's not going to be enough to meet that need, as I said. And even when there are psychologists in the field, a lot of them don't have the proper training or comfort level or experience to diagnose ASD. So there's a lot of variability and thresholds and consistency for diagnosing ASD at the community level. I see that every single day. There's a huge variability depending on who I send the child to as to whether or not I feel that they're probably going to diagnose this child appropriately. And for that reason, a lot of times we have our favorite psychologist that we know who's going to recognize certain things. So we need more training for those psychologists diagnosed for diagnosing ASD. If there's not a psychologist who diagnoses ASD in someone's area, typically they're referred to the Marcus Institute, which I'm sure we're all very familiar with, but it has 6 month or a year waiting list or more. So it's not really the solution. They're too inundated. And the delay overall is tragic. It's infuriating to parents because they're delaying getting help for their child. And of course, it does definitely reduce the prognosis for the child. So switching gears a little bit, because I know we only have so much time, experience with the educational system. So schools largely have inexperienced teachers and staff. Again, not just my opinion, but this is just a fact. Accommodations are slow to start. Typically, they're poorly followed on average. IEPs are often not given out anymore for ASD. I have numerous kids that I treat or young people that are not even able to get an IEP because they're told that they don't meet their criteria any longer. A lot of places have switched to the fact that you must have intellectual disability at all, in addition to autism, to get services of multiple kinds, including educational services, which is, in my opinion, inappropriate, because that doesn't mean that they're not struggling and need more services for a fair and appropriate education. But the problem is that there's a limited number of IEPs to give out throughout each community or school district, because this funding was frozen in the 2000s. So that's a big issue. So obviously the solution is to unfreeze the number of IEPs that are funded by the federal government. They shouldn't be freezing the number of IEPs because autism hasn't been frozen. It's going up, where the incidence is increasing. So it doesn't make a whole lot of sense to do that. As if the rate of autism is stable when we know it's not. Also, one problem that I experienced many times, and a lot of the kids that I treat experience, is paraprofessionals in the school systems have virtually no training. Unfortunately, they don't get paid a lot either, and that kind of compounds the problem. But in my opinion, the parapros should be RBTs, which is registered behavior technicians, which would require a standard level of training. It's about 2 weeks. It's not that much, and it's not that expensive, but they would have some level of training. So it would not increase the cost, as I say there. Parapros could handle the behaviors, and then the teachers could actually teach. One problem in the school districts is that they're just now hiring in the South BCBAs for routine use in the school system, but they don't use them very routinely and still pretty rarely, whereas the Northeast is much more advanced in this area. They have BCBAs to handle more behavioral issues in the Northeast. And of course, I'm cognizant of the fact that oftentimes the schools in the Northeast have more money. I get that. but there should be some sort of minimum standard that we have to meet. So more BCBAs should be hired in Georgia school districts and utilized by the school districts to let private ABA therapists into the school systems. But typically this doesn't happen. Usually the school system won't allow a private BCBA or ABA therapist of some sort into the school system. And I think mostly it's for liability reasons. But again, if your insurance is paying for the ABA therapy, it's not fair for the school system not to allow it if they're not going to pay for it. So another problem is there are good teachers who are very experienced, some of them with ASD, but they end up having to deliver watered down services as more children are placed in their rooms with severe behaviors. And I see this happen year after year after year, both personally and with some of my other, the patients that I treat, where the school year starts out okay, but as they start to move more behavior children into the classrooms, then the services become watered down, and eventually they're not really teaching hardly at all. They're just putting out behavioral fires and irritability and tantrums from the other kids. My daughter did very well in kindergarten with the low student to teacher ratio. As they added students, pretty much all education stopped. The most obvious solution is to allow a lower student to teacher ratio. Obviously that costs more money, I'm aware of that, but we have to have more one-on-one teaching with smaller class sizes. We know that that's how students learn best. We know that it's less overwhelming of an environment for the children to be able to learn. Also allowing an RBT parapro to manage behaviors would help the teachers be able to teach. So education doesn't have to stop in the room every time there's a tantrum. Very often IEPs are not followed or followed very well. Sometimes teachers don't even know what the IEP says, and I think that they're just overwhelmed. Parents, when the IEP is not followed, and I experience this myself, there's really no recourse. The most you can get in compensation is extended school year, which is a few extra weeks added on to the school year, but there's very little that you can do to hold the school district accountable. Filing a formal complaint is really helpful unless hundreds of parents complain at the same time, which is just not going to happen because it's not an easy process. So this is what typically happens to a lot of the kids that I treat. The parents end up homeschooling them. They often choose this because they're asked to get the children from school repeatedly after behaviors day after day. This causes at least one parent not to be able to work. This increases poverty, stress, causes less access to resources. If schools who have professionals there can't handle the child, how can the parent be expected to do so? It's kind of an embarrassing situation, in my opinion. And then when the children are sent home, you're actually rewarding that behavior. So then they're going to act out again so that they can go home, because that's what they want to do anyway, most of them. Homeschool reduces the much needed socialization that the child needs because they have autism and they have social skills deficits. And then it increases the burden on the parent. When my daughter started homeschool online with an ABA therapist that we had to pay for at home to help her, she excelled very easily. She actually gained three school grades in one year. She went from not being able to do simple addition and subtraction and the beginning of third grade to doing sixth grade work by the end of that year. It was quite telling. Class sizes are too large to allow for proper supervision and implementation of IEPs. We do know that those with ASD, again, do better with low class size and more one-on-one help. It's just a fact. Students are often forced into receiving a certificate of completion instead of a true diploma because of lack of available staff and educational services. The functional skills and often end up being taught instead of basic educational goals when a student has behaviors. Oftentimes, I think the schools aren't even capable of what the child's able to, or capable of knowing what the child is able to do educationally, because it's such a dysfunctional educational environment that oftentimes they're learning it, especially when they're in a self-contained class. So as a child psychiatrist, it's clear that I'm often using medications that otherwise would not be needed due to school system deficits. And that is a very frustrating reality. I feel like oftentimes I'm going up on someone's Abilify or Risperdal, their atypical antipsychotic, because things are so stressful and overwhelming in the school environment. But the problem is that's not likely to go away. So the problem is good teachers leave due to unethical demands of the school system at times. It's due to poor funding, poor education, training, and money not following the child. So one solution that's talked about frequently is resources following the child in different areas of mental health or education or government. And so money really must follow the child into the classroom so that the resources that the child needs is actually put into that room, into that teacher, into whatever it is the child needs. We must have required autism training of parapros and even SPED teachers. It's really not an option. Many teachers have told me that they feel threatened against complaining or helping the parents too much. In other words, telling them what they should put in their IEP to get more help. Also, I didn't put this in here, but it often is an issue that a parent has to hire a special needs advocate just to go to the IEP meeting so that they are able to get access to reasonable resources, which also should not be necessary. So the problem is the school system has a monopoly, this is my opinion, over the citizens and discriminates against those with special needs regularly to save themselves money. The fox is guarding the hen house, essentially. In my opinion, an independent third party should run the IEP or make resource allocation decisions, because of course, if you're an administrator for the school system, of course you're going to want to give out less resources. So it creates an interesting dynamic there. Although there is a special needs voucher, which is actually fantastic that we do have that, actually, that's a huge positive. There are very few private schools that accept that special needs voucher. And then likely that school still would probably not provide the resources that that child needs because those resources are expensive. So talking about the medical community some more, in outpatient psychiatry, there are very few child psychiatrists, as we already know, and there's even fewer that feel well-trained or willing to care for those with autism spectrum disorder. There have been times, my daughter's 17, there have been times where she hasn't even had a psychiatry provider because they're so difficult to find. One that we had moved to another state, and there are various other examples, but it's very difficult to find someone that provides decent care for autism. Very few child psychiatrists, again, try to get more training or further training to be good with that population. And to be fair, I might not be as inclined to do a great job with autism either if I didn't also already have a lot of experience in having my own child with autism, because they are a much more difficult population to treat. So when there's an emergency in the state, DBH, DD, and EDs are almost no help at all. Unfortunately, I know that they've made strides, but we are far from where we need to be. As Dr. Lukowitz stated, the emergency departments get clogged very easily in my community, and I'm sure most communities, with ASD patients in crisis. I would argue that 9 out of 10 wait for so many days in the emergency department that the parents even ask to go home. And it kind of leaves you feeling, and I feel guilty too, because I'm on call for my emergency department, and I feel guilty that there is no place for these people to go, because I understand that these people are in crisis. And what happens is, after that happens once or twice, the parents just stop coming to the emergency department. And the feeling is, well, that'll teach them to ask for help. They're just gonna have to camp out in the emergency department until they finally get tired and go home. There's only one facility in Georgia that takes acute ASD patients for inpatient, and it's almost always full, and they don't have tons of beds. This leaves parents all alone, essentially, to deal with unsafe children. There are essentially no emergency services for ASD. When mobile crisis comes out, they recommend admission, which isn't usually possible, or follow-up with outpatient services that either can't get quickly or that haven't already been helpful. So the solution, there should be incentive to open acute autism units, such as better reimbursements, or the state must fulfill its responsibility to care for its citizens and open autism crisis stabilization units. I've been told that there is one, that there is an autism crisis unit recently. And ironically, when my child was in crisis, I looked into that unit. That unit has such a narrow age range that like hardly anyone fits that criteria. When rarely an acute unit admits an ASD patient, care is often substandard due to needing more specialized care than that unit can provide, such as a BCBA and ABA therapist, more one-to-one care, or just even space to separate that child from the rest of the unit so that the rest of the unit can function appropriately. One could argue that acute inpatient units refusing ASD is clear discrimination, which is why I feel guilty sometimes when we're refusing ASD patients to my own unit. But the issue is that they're not equipped due to money, more space needed, staffing limitations, again, not having behavioral therapy. You could end up in a situation where an acute unit is actually doing more harm than good. Units can't afford the extra staff since they barely break even often with typical patients. More incentive is needed, again, for psych facilities to care for these patients, such as higher reimbursements for the diagnosis of autism, or if they need behavioral therapy or some sort of thing like that. In my opinion, both as a professional dealing with kids with autism that can't get services, it's just unforgivable that there's a lack of emergency and urgent care for this population. Another facet of the medical is not just inpatient, but residential. So most residential facilities, it takes 6 months to a year to get in for pretty much any diagnosis most of the time. In Georgia, the problem is there's only one residential treatment facility, Laurel Heights, that takes those with ASD. They don't even take females. That was a problem in my case with my daughter. But it's a huge issue. That's not enough. They don't have enough beds to accommodate the entire Georgia need. So the solution, there should again be more incentive to open up private residential autism units, residential units, such as better reimbursements, or the state's going to have to step up to the plate, which I don't think is going to happen, to open up those units themselves. So here's my experience with acute residential needs that I've had recently. So my daughter had needed acute treatment before, numerous times, but as a child psychiatrist and having a lot of knowledge about autism, we handled it as best we could at home for years. And it was usually because there was no inpatient unit to take her. When she was 17 years old, we were in desperate crisis, and this was basically less than a year ago. She had been eloping to the highway. She became a danger to herself and others. She was actually hit by a car during one of these episodes in the middle of us trying to ask for help, but there was no help to be had, basically. We were told to call mobile crisis, but we knew all they would do is tell us to go to the emergency department and wait until there wasn't a bed, because I know how the system works. So she literally needed 24/7 supervision for safety. Only Laurel Heights would technically take her for acute inpatient, but they were always full. I had to call every day to see if they had an opening at a specific time each day before the bed was taken, but it didn't help. We couldn't get a bed. So we waited about 4 to 6 months for in our acute crisis, waiting for a unit to be available to take her. So I literally had prepared in my mind that she was just going to die. And once I had to chase her down a highway and had to tackle her in the median, and people called the police and they came out to get her and just took her home. But there was really nothing that anybody could do. We called facilities all the way from Atlanta to Boston for residential, for acute, anything that we could get. But there was always a different reason that she could not be accepted. Either it was an insurance issue, there were no beds, she was too close to 18, some of the units didn't go higher than 18, there was a 1 to 2 year wait list. I still have some places that still have not called me back yet. Some don't accept insurance at all. It would be like $200,000 a year, like anyone could afford that. But mostly there were just no beds. There were just no beds anywhere. Finally, after 4 to 6 months of crisis, she was accepted to Springbrook in South Carolina to their acute unit for 1 month. But there, the acute unit only accepted Blue Cross Blue Shield, and their residential treatment facility only accepted Medicaid. So it was quite the conundrum. So, and there were more issues related to that, but there's always some sort of barrier. Navigating treatment is like a roadmap through hell, like literally. And that's coming from someone who's educated and knows what the treatment options are and understands how to get help, and it's still almost impossible. When she was inpatient, we got calls each week that the insurance was denying days and that we would owe $2,000 per day. Finally, we just had to take the risk and appeal with our fingers crossed, hoping that, that the appeal would go through. And they would literally call. Some days we would be actually on our way to South Carolina to get her when they called, oh, they approved the appeal, it's okay, you don't have to come and get her yet. So, and of course we wanted her home, but we wanted to know that she was safe and that she had gotten the care that she needed. And again, just as we're probably used to, medical doctors are not the ones who dictate when the patient's ready for discharge, it's insurances. Again, in residential, we had the same thing. Every couple of weeks, we were threatened that the insurance company was about to deny for help. So you have this roller coaster of emotions just getting her somewhere. And then when she gets somewhere, you constantly don't know if they're going to discharge her too early or if you're going to have resources set up when she does come home. So it's a battle even when it shouldn't be. So talking about government resources further, I found them to be almost impossible to access, very slow, confusing, and I'm not the only one. I have tons of friends that have children with autism that experience the same things. I have patients that experience the same things. Katie Beckett is very difficult to get. Most parents get overwhelmed and give up. They don't even try. Some don't even know that they're supposed to be getting Katie Beckett, or there's a Medicaid waiver available. No one who's going to tell you that those things exist. I mean, doctors are not experts in that information. So it took me 10 months just to get all the paperwork for my daughter, like literally many stacks, like this tall of paperwork that I needed to just apply for the Katie Beckett waiver. In my community, parents are laughed at by the state for hiring a special needs advocate to file the free paperwork. But if you don't do it, you're going to fall through a crack and you're going to get denied. We had to hire a special needs advocate that cost us $7,000 just to help us after I did all the work to get the paperwork. So the problem is parents cannot navigate this. It is just almost impossible, and especially when they're barely surviving. The solution is the needed documentation can typically be found within the school system already. They already have the psychological evaluation. They already know the child has autism. They already know that their IQ is 50, 60, whatever. They already know that. Why do they need the stacks of paperwork to be able to say, yep, your child deserves the Katie Beckett. Yep, your child needs the Medicaid waiver. The process is lengthy. It takes many, many years. Once you even get approved for the Medicaid waiver, you know, it could take, again, many, many years, up to 10 years. So you just don't know when your number is going to come up, so to speak. So I liken it to needing unemployment, but you might not get it for 10 years. It just doesn't make any sense. I know that there's a resource problem, and that's somewhat understandable, but the situations from an autism parent perspective is ridiculous. So solution, Georgia needs to continue to give more resources to Medicaid waiver program, which they are. I mean, we're making some progress in that way, which is great, but we just need more. So with the police, many people with ASD elope, like at least a third of them. So often these children are brought home by police. Often police don't know how to handle these situations. We were fortunate with my daughter a couple times when she was finally found and brought home by the police. They were actually very nice, and they actually had a dedicated person that was on staff at all times. I think there were like 2 or 3 of them. They were on staff at the police station at all times that had special training on autism. So their entire police force was not educated, but they had one person that showed up every time there was an issue with an autistic child or adult. And so that was very helpful. But I don't think that every community probably has that, but we need more training for police and social workers. This is my last slide, and I wanted to bring this up because I think that most of us can understand how serious this situation is. It's the story of Andy. This is a person in my community. He's actually the brother of someone that I treat. He was admitted to a pediatric hospital here where I'm at in Columbus, Georgia. He's a 3-year-old child with ASD. He was admitted to a peds floor with cold-like symptoms. The staff couldn't give IV fluids as he kept pulling out IVs. They were struggling with him. They didn't know how to deal with him. They didn't know how to handle, and again, keep in mind he's 3. So I would argue that most kids might do the same thing anyway, not just those with autism. But then the staff couldn't give him O2 reliably. His mom was forced to hold the O2 mask over his face for 6 hours. No staff entered the room. No one was helping her. She was falling asleep because this was like in the middle of the night. When he was finally transferred to the PICU, his needs were not addressed due to his ASD, as if they had rarely had ASD patients there before. He coded without them ever intubating him, keeping an IV, anything. His mom said that he died because he had autism. And again, this just happened 10 days ago. So the solution is mandatory autism training for hospital staff, especially on PEDS floors or in PEDS hospitals. The resources to help with the above medical issues mentioned that were complicated by the ASD. Need more autism-friendly environments, rooms, that sort of thing. So I know I went over relatively quickly a wide range of things. I apologize for that, but I tried to make it more problem and solution oriented so that it wasn't simply just a complaint fest from an autism parent. But there are a lot of needs in Georgia, as I know you all know, and we've made some progress, but we have a long way to go.
Thank you, Michael. I really appreciate this. This was it certainly tugged at your heartstrings, and I appreciate this. This is helpful for everyone. Let's go ahead. I don't know if we want to. Let's go ahead and let Dr. Constantino talk. I know we're running a little bit late, so I think that let's go ahead and do that, and we'll have questions later.
Eric, what's our time frame for the meeting? Because, well, what is the time frame for the meeting?
Well, so technically 5:30, but we went over last time.
Okay. Well, I think the most appropriate thing to do after hearing Michael's talk is to pause for a moment. I want to reinforce just about everything that he said as a clinician, as an advocate, as a dad. What you were just treated, we were just treated to a tour de force of knowledge and recognition of where there's actual hope, where there are real levers to be advocated for and pursued. So Michael, I endorse it all. And I think maybe a first thing to do is just to pause for a moment if any of the committee members wanted to, react or ask qualifying questions, because I have things that I'm glad to present, but I really do want to, I think the thing to do first and foremost, my background is in science and public health, and clinical care of children with autism spectrum disorders and the broad array of serious psychiatric conditions of youth for 30 years. And Michael is right. So maybe just pause there. I don't want to delay everybody further, but I do want to make room in case there's any kind of appropriate reaction to this poignant conversation. I don't think it's only a heartstrings tug. It's reality. This is clinical truth and science and direct observation. And I've only been in Georgia for 2 months, but I was in Missouri for 30 years of practice, and that is the same story.
Yeah, so I think the desperation that parents feel is really hard to get across, and I think you did an excellent job of sort of putting it all together, because it's not just one thing; it's multiple things, and it's really hard. And I see families that are at their wits' end, and these are bright, educated people, and we try to help them. I mean, I spend time, because I feel like I have to, because nobody else is going to do it, telling them about Katie Beckett, helping them fill out the forms, because otherwise it won't get done. And then they don't really have the opportunity to get the services that they need. So I knew that, I knew your experiences, not all of them, but I knew that it would be appropriate to set the tone for this meeting.
Yeah. Well, I did want to honor the gravity of that presentation. If you'd like me to, I think I have some things that I could present around the edges of that will also bring some of these points into a different kind of focus that might be helpful for the committee. If you guys would like me to proceed, I'm glad to do that. But again, I want to very much honor this. This was a wonderful presentation. This was a treat for everyone. And when you're in autism research and public health for a while, you hear a lot of presentations. This one ranks right up there. It was very, very, very good.
Thank you. I appreciate that.
Yeah. All right. Well, let me share my screen. And let's see. Can you see that?
Yes.
All right, let me get into presentation mode here and back up. Okay, well, so first let me recognize a couple of people that are on the call today that I've had the very good fortune to meet already in my short tenure as Chief of Behavior and Mental Health for Children's Healthcare of Atlanta, and that's Gwen Skinner and Sarah Vincent. In the meeting today, and I have already had a great opportunity to have first interactions with them, and each of them represent to me, people who are pioneers and in pivotal places in the response not only to the needs of children with autism, but the needs of children with all mental health conditions. And so it's wonderful to see them today. Eric, thank you for the invitation to present. My reason for being here, so my background, just to say a little bit about that, and why did Eric even ask me to address the group? My background was at Washington University in St. Louis and St. Louis Children's Hospital. I led the division there for 12 years. I had a research program in autism, much of which revolved around the two central issues of the causation of autism, what actually causes autism, and also about the very diagnostic issues that Michael pointed out that have been huge obstacles to service eligibility for children. And I'll say a word about that. There's plenty to say about that, but I had a laboratory there. I led one of the 14 U.S. Kennedy Centers for Developmental Disabilities, and for a time I chaired the State Mental Health Commission in Missouri for the Department of Mental Health, and I left it all to come here. And why did I leave it all to come here? Because at this phase of career, after being with families and patients exactly what Dr. Ellis described. I think for our field, I'm a child psychiatrist like him, and he may agree or disagree with this, but one of the most important things now that the leaders in child psychiatry need to do is find a place for the health system to own what is possible for our children. Michael pointed out a lot of solutions, a lot of what is possible, a lot of what will make children better. And this is true not only for autism, this is true for our entire field of child mental health. And the problem is, for lots of complicated reasons, is that the field's been backed into a corner where the system of care for most children, most states, most cities, most strata of the population do not have access to what is the evidence base of the science of our field. And I came to Georgia because Children's Healthcare of Atlanta and Emory teamed up and at least brought to the table a kind of galvanization of intent, will, resources to take ownership of a higher level of mental health care system-wide for a truly representative population of children, which Children's Healthcare of Atlanta covers, is invested in taking care of. And so it became a proposition of health system ownership for equitable delivery of the evidence base of our field. And where I came from, there were no takers of that proposition. And this organization represented that opportunity. And so here I am, and I'm 8 weeks in. So I don't know a lot yet, but I'm happy to be here to present to you today in response to Eric's invitation. And what I think I'll do is adjust my remarks to, in some senses, window dress what you were just treated to in a kind of a whistle-stop tour through what our opportunities are in autism spectrum disorder. And first, and I just made this slide while Michael was talking. So, and I was listening at the same time, Michael. I was multitasking. But there were three things that in your solutions deck that you pointed out that I think are very, very important things to consider, not to pick on the insurance companies, but I'll pick on the insurance companies for a minute as our partners in this, that there are things that could be done to remove some of these barriers. So it is 100% true that when an insurance company sets an eligibility criterion of a psychologist diagnosis, they introduce a 1-year bottleneck. We have written about this. We've published a path through. Here's one publication. Primary care physicians, nurse practitioners can be empowered to make appropriate and valid diagnoses. That has been proven. And so there is a pathway for that. And it is a nuanced form of reform that I think is a very worthy target that Michael presented. And I think it's within reach. And I definitely think that this is something that's worth very serious consideration by all of us collectively as a community. The second thing that Michael mentioned is the individualized education plans. And there are different ways to get at making sure that what a child does for 6, 7, 8 hours a day of their life, if that's not calibrated to what they need educationally, which they're entitled to as a federal entitlement, they aren't going to do well. This was very eloquently, described in your presentation. And there are lots of ways to get at that, but one of the other ways to get at it is for the doctors who are involved, and the psychologists and the nurse practitioners and the physicians, to participate in the IEP meeting. There are, lots of person hours that are spent, Michael will attest to this, in IEP meetings, but very often there is an absence of the principal leader of the clinical program for a child that is involved in that meeting. And we piloted this in St. Louis over 30 years. And I trained all of our fellows, our child psychiatry fellows, that at the critical juncture in the life of a child with autism, your job is to conference call into the IEP. Now it's better than a conference call, it's a Zoom meeting, so you can actually look at each other in the eyes. But when people ask me as a 30-year clinician, what's the highest impact that a child psychiatrist had on the children, the group of children that I took care of over the years, and people have all kinds of expectations about what I'm going to say about which medicines I use or what magic we did or whatever. And I always tell them it was conference calling into the IEP. As a clinician and as a scientist, I will go on record to say that was probably the most potent way that I helped the children and families affected by autism in my 30-year practice of caring for this population of children. And then the final insurance-related issue that's very practical that Michael brought up had to do with inpatient care. And he alluded to one or two agencies that provide inpatient stabilization for children with autism, there's actually a collection of neurodevelopmental disorders units around the country in various states that have figured out ways to partner with the insurance companies that are involved in the plans for the children in those states that manage Medicaid and so forth. That the cost of doing business to deliver that kind of care is a different level of care. But some of the very successful places that have done this around the country. So Matt Siegel this is a publication from that group. There's a group of them. There's somewhere, I don't know, Michael, you might know, there's about 8 or 10 of these sites. And they've all figured out ways to just get the adjustments to the rates, not in a per diem way, in a per service way. Often that this is just what it costs to actually take care of children in this particular category. Gwen is also very familiar, I think, with this whole, calculus. And this is a way that these units have thrived. So if you talk to Matt Siegel, who's the kind of father of this group, he's at the University of Maine, and he can tell everyone, this is what we had to do to get the insurance, right, so it was paying for the actual cost of care, and so that we could make it, viable and sustainable. These are real targets. We can get there. And Gwen's situation for more long-term residential care is different than some of the objectives for short-term residential stabilizations when there's a crisis and one needs to just figure out how to revise care. But these are targets that I think are very worthy of pursuing. And I'll just leave it at that. And just to reinforce some of the points to kind of galvanize some of the many solutions that Michael referred to into kind of an insurance bucket that that might make sense for the committee to kind of think about. Well, let me just make a few other kind of points that I thought would be useful for the committee to kind of have awareness of or to talk about. And I'll try to keep it to within 5 or 10 minutes, so there's clearly time that we can talk and digest some of this, or any way that I can be helpful. So one of the things that we've learned in autism, if that hasn't become sort of clear by now, is that for the population burden of autism, so if you think about how common Dr. Ellis presented, how common autism is, when you ask what causes autism, overwhelmingly, the cause of autism is genetic liability. And people argue about why would genetic liability cause so much increase in the prevalence of autism that we see today. And the fact is that essentially what we've done is somewhat broaden the diagnosis of autism, but in a very appropriate way, because the children that we diagnose with autism are truly impaired at a level of compromise to their ability to play, to work, to love, to form relationships. And so we are not overdiagnosing autism, but if you use our current diagnostic definitions for autism, and you use those on older cohorts of individuals, and this study has been done. So you go back and say, well, if we use our current definitions for autism and apply it to 40-year-olds or 60-year-olds in a US or a UK population, how much autism was there for those 40 and 60-year-olds, because they lived and grew up in an era where there apparently wasn't any autism? The prevalence is exactly the same. It's exactly the same. And so the fact is that we've recognized these syndromes in a much more complete way, which is great. And when we really look at what are the causes of that, a lot of that is, is very much like many complex diseases, diabetes, heart disease, many of the psychiatric disorders, a very, very significant influence of genetic factors. And that doesn't mean that we can't treat autism. It just means we have to be clear that what we're dealing with and what we want to try to help children and families with is with a condition that's very often strongly genetically influenced. And where do we take that forward in terms of our approach to what's possible? And the fact is, and if you really look at the treatment literature, and this makes people feel very discouraged about autism, is that when you try to actually treat the core symptoms of autism, social impairments, the proneness to repetitive behavior or rigid patterns of thinking, it's very difficult to budge that. Even our best treatments. And so some people will think, oh, well, autism treatment doesn't work because it doesn't move the symptoms. This is a 10-year longitudinal study that we published in 2019 among a wide range of children, but particularly a group of children who were actually treated with the best treatments that we currently have for helping individuals affected by autism. And if you look at the maternal ratings of how severe their core symptoms were at baseline and how severe their core symptoms were at follow-up over a 10-year longitudinal study, there's not a lot of change there. That when you see a scatter plot like that that runs along the diagonal, what you had at time 1 is what you had at time, down the road. These symptoms are very stable over time, the core symptoms. But adaptive function is a completely different matter. And so one has to be very careful to disentangle, can I cure the condition from, can I improve the life of an individual who has the condition of autism? And the answer to that is an unequivocal yes. And Michael presented, some of the best cases for the kinds of therapy. This is one of the developmental therapies, ABA-based developmental therapy, which basically tells the story of the more of that you get when you're little, and the longer you get it, here is where the improvements are. Social adaptation, play, motor skills, language, executive function, your IQ, your overall adaptive behavior, and your academic achievement. Now, not one of those are core symptoms of autism. Not one of those are, specific abnormalities of eye contact or specific hurdles with moment-to-moment, social reciprocity or repetitive behavior. But think about it, that treatment and our best targets and our best outcomes are in adaptive functioning. And everything that Michael presented about getting a child better, not only improving their overall adaptation, but also treating them when some of the behavioral overlays get in the way of their best function, their ability to respond to their teachers, to hang in there with their friendships, to stay in there to hang in there with a job and an occupation. And that we can do. So my first point that I wanted to make is that it's very important to not only avoid, but combat therapeutic nihilism, okay? Because when people say you can't cure autism or you can't treat the symptoms, that is not the same as saying you can't improve adaptive functioning. And this is so worth, and for all of us, adaptive function is how we define, our life, our happiness, our families, and so forth. And so these needles are movable. The adaptation end games vary through life. And this is something that people struggle with a lot, because at first, the most important adaptation end game for young children with autism is getting them to have a form of language, whether it's verbal communication or sign language, or using now a technology, a tablet, to help them communicate, or functional communication training for older individuals that still have a lot of struggles with language. Prognosis in autism, if you ask what is the best predictor of the life outcome of an individual with autism, there's lots of predictors of that, but by far the most productive, the most potent predictor, the most robust predictor of life outcomes for individuals with autism is their capacity to communicate. And so this is the most important thing. But as they move out of toddlerhood, and as they acquire whatever they're going to acquire in terms of communicative capacity, look at some of these other adaptation targets: the capacity to regulate emotion, their social relationships, even through the lens of autism. Children with autism have struggled with social relationships, but that doesn't mean that they don't want them or that they can't gain them, right? Academic achievement, identity, romantic relationships, work. And each of these different phases of life require, a different game plan or a revision of the game plan. And so I think it's in thinking about the longitudinal support of a person with autism and the ability of people to support their best adaptation, we have to think about each of these phases. And there are things that we can do at each of these phases. And oftentimes a child with autism will get access to somebody really good that does one thing, but they don't know how to do the other thing. The people who are really good at preschoolers aren't that good at adolescents necessarily. That's not always true. I don't mean to make a generalization about that. But we have to think about our systems of care as children with autism grow up. And that's a real opportunity for us to think about, the continuity of supports across the lifespan. Now, two other points that I want to make, and then we can kind of pause and talk. One of the very difficult realities about autism and adaptation and early treatment of autism, if everything that Michael said didn't kind of move you to a place of we have to do something about this, take a look at this slide. This is data from the Centers for Disease Control that's now been replicated 4 times. Okay, and on this slide this is the slide of essentially this. If you have autism, if you're a child with autism in the United States, what are the chances that you also have intellectual disability? Okay, and what you can see here is that if you're white, non-Hispanic in the United States, that runs about 20%. If you're Black, non-Hispanic, the prevalence is identical. It's apples to apples in the denominator of how many kids in the population have autism. And that was true in each of these studies. The likelihood that you have intellectual disability is 50%. That is a very serious health inequity. And the causes of that are a long discussion, but essentially our laboratory went about the process of dissecting that disparity. And to make a very long story short, basically, it is often the case. This is true for all children. So I'm not presenting this only for minority kids, but for minority kids, it's especially pronounced that there are long delays between the time when parents raise first concerns about their children and the time that they get diagnosed, for all the reasons that Michael said, and that the difficulties with service access, diagnosis access, all of these long delays really work against under-resourced populations in a particularly cruel way. 42-month delay on average for children. And so we know that a lot of that has to do with difficulties with service access for populations, and taking away ready eligibility and diagnosis for service access just makes the problem even more acute. When we dissected this problem and reported the results in the Journal of Pediatrics, this is an editorial that was written about our study in this, which was titled Structural Racism and Autism. And just like the solutions that Dr. Ellis presented, this article gives a roadmap for what we must do to resolve this inequity. And this is a pathway that's appropriate for all children, as far as making sure that those diagnoses occur on time. We then went on to determine, in a population of African-American children suspected of having autism, whether you could speed up the timing of diagnosis if you just go out there and conscientiously set up a program for diagnosis that has no delays and no waits. And we moved up we were able in St. Louis and in Atlanta, this was actually a collaboration with Emory. We moved up the timing of diagnosis in a representative population of children with autism by 3 years. And we also showed that if you can get those kids into the kind of developmental therapy that Michael described, that about every month they gain 1 IQ point. Okay, that if you get them into therapy, that they're gonna start making progress. And so, you know, those advances are possible. They're within our reach, but we have to make them possible. And so, again, going back to this issue of making sure that there are no unnecessary barriers to a diagnosis, that a primary care physician who's armed with knowledge and the right kind of metrics to be able to document in a standardized way what is the symptom burden of a child. These are very important things. Okay, finally, I think we have one other area I want to just mention that again was reflected in the discussion about what happens when a child with an autism spectrum disorder ends up in a behavioral crisis. One of the problems is that it doesn't have to wait until there's a behavioral crisis, because there's actually an evidence base for what to do when a person with autism begins to develop aggressive behavior, begins to develop anxiety, begins to develop depression or a substance use disorder or mood instability. And so, but a lot of people aren't trained in that interface of what we'll call dual diagnosis. And it's a small literature, but it actually has its own literature. And we recently went about culling the scientific literature for the evidence base for what happens when you have joint liability of autism or an intellectual disability with a behavioral syndrome of aggression or substance use disorder or depression or anxiety or mood instability. And I just wanted to point out that there's now a place where people can get access to this. This is a public access article. And we turn the article into a smartphone-based app. So you can go to one of these sites, and it's sponsored by the Missouri Department of Mental Health, and you can pick up this app, and it will, instead of reading a boring article, peer-reviewed article in the scientific literature, it basically takes you through a decision support process for dual diagnosis, where first you have to recognize and diagnose the syndrome. You have to make sure that you're minding the store of ensuring safety for an individual with a dual, with a evolving dual diagnosis. Consider all the biological and medical factors, consider all the psychological and social factors, consider unresolved trauma, and then devise a comprehensive intervention plan that's based on what we know one can do if you follow the evidence base for when these factors are at play. And so why don't I stop there? I just wanted to mention that when this kind of knowledge is imparted through the ECHO method, which we have done in the state of Missouri now for a couple of years, one of the things that you turn up as the missed opportunities for treatment for these individuals and families goes right back to Dr. Ellis's presentation. So in ECHO, you do a case conference, and you say, what if a person with these dual diagnoses is struggling, what else could we be doing based on our evidence base and what we've learned from presenting these cases and hearing about these cases is there's elements of history that are missed. There are things that are not understood about who are the owners of decision-making for the care of the patients. There's been lots of difficulty with incorporating ABA-based methods, not only for developmental therapies, but for behavior support plans, which are very powerful tools that often people just don't know what they are, and need to be armed with information about how to access them. The use of psychiatric, interventions when they're necessary need to be, capitalized on, and recognizing trauma and functional communication deficits and really targeting them. Those are within our reach. And so, so anyway, let me stop there, because I think what I just hoped to do there was to help round out this sense of great opportunity And my hope is in my tenure, which is supposed to span the entire scope of mental health services for children. But autism is a great example of where there is great opportunity and missed opportunity that capitalizing on some of these really smart, really strategic solutions as presented by Dr. Ellis, I actually think we have lots of opportunity to work on together. And I will greatly look forward to working with all of you as we, move forward and build on everything that's been done in the state. So I'll stop there. Thank you, everybody. Eric, you're muted. So if you're saying something,
Thank you. That was that was wonderful. A great way to put the topping on Michael's presentation. Yeah. So I appreciate that. I understand that Bhavini has to leave. So I just wanted to be fair to our other speakers. Sanita and Malia, are you okay continuing today?
Hi, yes, I'm okay continuing. This is Sanita.
Okay.
Hi, this is Maliha. I'm okay to keep going as well.
Okay. So do we want to give people an opportunity to ask Dr. Constantino some questions?
Eric, I will still be on the call, but I have to be in the car driving to my next meeting. So
Okay.
I'll be listening to the presentations.
Very good. All right, well, then let's, so I guess we'll go by the agenda. So let's have Sanita go ahead and provide us with her words of wisdom.
Thank you so much, Eric. I will go ahead and share my screen. Hopefully you guys can see it right now.
Yes.
Awesome. Well, again, good afternoon. My name is Sanita Griswell, and in my role as the Autism and Developmental Disabilities Program Manager for the Georgia Department of Public Health, I'm very excited to share with you the state of autism spectrum disorder as it relates to the Georgia Autism Services Initiative. Quick overview of what we'll discuss in my presentation today. I'll share with you the federal and state health objectives that is overarching to our program, as well as touch on some of the health burdens for children in autism, as Dr. Ellis and others have presented on very eloquently, so won't need to spend much time there. I'll also share the program strategies that we utilize for addressing these burdens, as well as discuss some of the referral processes for accessing services in our child health system, as well as wrapping up with program services, some annual activities, and some resources, and finally touching on some of our internal and external partners. So the Autism Initiative is governed, or the overarching Healthy People's 2030 objective is the Maternal, Infant, and Child Health Objective 18, which states to increase the population of children with autism spectrum disorder who receive special services by age 4 years. And as we've discussed, as reported by the CDC, 1 in 46 children are identified or reported to have autism spectrum disorder. This graph just shows the increase in prevalence over the years. The Georgia Autism Services Initiative is a service delivery system to improve Georgia's capacity for early intervention, screening, diagnosis, intervention, and transition planning for children and youth birth to 21 years of age. It's also important to note that in 2019, direct services were implemented with the support of our Part C program, Babies Can't Wait. Core to our strategic mission, which addresses the maternal and child health, Healthy People's 2030 Objective 18, is educational outreach to raise awareness, training providers for capacity building, early detection and intervention, as well as screening and standardized screening. So we achieve this strategic programming through related cross-cutting focus areas, such as addressing parental concerns through family engagement, again, establishing standardized screening practices, and strengthening our federal and state partnerships. As you can see on the map here, there are 18 local public health districts that cover all 159 counties. And each of these local public offices, there is a coordinator that is responsible for delivering direct services to children and families, including early intervention services. Early intervention services include a menu of offerings, for example, assistive technology, audiology, evaluation and assessments, health and medical services, nutrition services, physical and occupational therapy, psychological services, service coordination, social work, special instruction, speech language pathology, and vision services. And behavioral intervention is one of the most recent additions to this menu of services. A bit about our referral process. Referrals of children birth to 5 years of age to the public health services system, including EI services provided through BCW, come through our Children's First program. Children's First is Georgia Maternal and Child Health Program, single point of entry program. So those referrals are again given to Part C through the Children's First program. And here is a depiction of our referral form. It can be found on our website, and it is also electronic, PDF fillable and electronic, where you can send it directly to the health district where a child and family is in need of services. ASD MCHAT RF screening. Wanted to share a bit about our annual screening practices. Annually, the program screens an average of 4,000 children for ASD at both 18 and 24-month intervals. Our service coordinators do utilize the MCHAT screening for many of the purposes and reasons that have been stated here during today's presentation. And of course, is a parent observation screening tool. So it helps us to have that parent engagement during this time. We do want to acknowledge the AAP from which our screening recommendations are derived. We also recognize the comprehensive system of care model that identifies the primary care physician as the first screening or first place for screening. Our program primarily works with those families which for various reasons may not have had that completed well-child visit, or sometimes families might fall through the crack and they're not aware that they have even received a MCHAT screening. So our service coordinators work diligently to gather that information from the primary care physician, or if they aren't able to gather that information, they offer the screening to the family. So we really serve as like a catch net for those children and families. Sometimes we realize that transportation can be a barrier and many, many other reasons for attending those well care visits. However, we do highly recommend and encourage, and our services are comprehensive where we are supporting the family in getting those well child visits completed. Our annual activities around screening do include increasing the number of professionals trained to provide the modified checklist for autism in toddlers within our public health districts. Annually, we see approximately 200 to 300 service coordinators take our MCHAT screening training, and that training is accessible throughout the year, where providers will go back and they will refresh their knowledge and education on identifying red flags for autism as they are conducting the modified checklist within our public health districts. We also implement screening and track data collected on children screened at recommended periodic intervals, 18 and 24 months. So through program evaluation, program analysis, we are constantly looking at our data to see how we can improve any of these activities around screening. So we understand that not all children screen for developmental issues during well-child visits, and screening does not always catch the concern. The importance of ongoing monitoring and possibly screening by caregivers, daycare, preschool, and other professionals is definitely vital to our overall system of care. So again, the department serves as a safety net for those families who may not be aware of these screenings and are looking into more developmental monitoring while they are seeing our service coordinators. If the concern does arise, we again offer the screening to children and families. So just to touch briefly on developmental monitoring, we do offer continued education and really family engagement to encourage and increase the level of developmental monitoring. We understand that the sooner concerns are identified, the sooner we can start the process of intervention and getting services in place. So looking at tools such as the Learn to Sign, Act Early, offered by the CDC, other ages and stages developmental screening tools, again, as well as the modified checklist for autism in toddlers. And really just wanting to highlight the use of this tool and how it has really helped our providers understand the variance and the vast sort of spectrum that children come to us who we see have a concern of ASD. This tool has really helped our providers understand the communication nuances, the differences in social responsiveness, as well as some of the behavioral challenges. So again, our program primarily supports children at the 18 and 24 months during this screening period, and then eventually moving them on throughout the process if we do identify a concern. So annually, the program facilitates an average of 200 diagnostic evaluations with some of our larger districts, such as Cobb Douglas, Gwinnett, and Athens, performing high in this area in terms of diagnostic evaluations. Similar to many other programs and state agencies, we do sometimes have a challenge in terms of providers in this area. So we are very pleased to see this number increase over the years. We have partnered with Emory Autism Center for several years on a project that trains community and licensed psychologists on administering the ADOS, the Autism Diagnostic Observation Schedule. And at the peak of this initiative, we were able to train and partner with 54 licensed psychologists. Our goal was to have them spread out across the state in each of the public health districts that we discussed previously. And we are continuing these efforts for continued education and really just building capacity in this area for diagnostic evaluations. So a bit more about our annual activities related to diagnosis. We do aim annually to increase these efforts by 5%, especially when it comes to our professionals that understand how to deliver an ADOS to children and families. And again, this community of licensed psychologists, we refer to as the Georgia Autism Assessment Collaborative, or also known as the GAT. So there is a general community of licensed community psychologists, as well as a group that we refer to as our specialty clinics that have committed to intensive or more in-depth training and education around autism, as well as linking some of those comprehensive and wraparound services within their community, such as partnering closer with their Part C program in that area. We also, in activity 2 related to our referrals, children who receive a negative or fail result on the MCHAT assessment are referred for diagnostic evaluation within our program. And most recently, we have launched a initiative or pilot initiative, again, in collaboration with Emory Autism Center, where 3 public health districts have been chosen to participate in what we identify as the early diagnostic response model, those districts being Dalton, Dublin, and Waycross. And within this pilot, we are testing the use of technology, telehealth, as well as the collaboration and partnership with our Part C programs to really get diagnostic services out in our communities that we see are really challenged and struggling with this service. For instance, we know Dublin has been an area where resources are very scarce. So we single-handedly, went to this district and worked with them on their participation so that we could infuse services and resources within that area. Also, children receive an ASD diagnostic evaluation. Our goal and our aim is for that to take place within 90 days. That continues to be our goal. However, sometimes due to a lack of providers, that is a challenge for the program. ASD early intervention services. So we do work in established partnerships and contracts with ABA providers. And services are individualized and family-centered. So our ABA providers are working within the home to deliver services. And we've seen quite a bit of uptake with this model, although we know typically ABA providers work in either school setting and center-based setting, and children and families do have the option to pursue those services as well as receive services through our BCBAs within the program. So this is just a bit about our annual treatment service referrals. Annually, the program facilitates an average of 100 referrals for early intervention, meaning early intervention delivered by our BCBAs and or RBTs within the program. This is a depiction of our service delivery from 2021. And you'll notice that there is a peak during the month of May. From the research that we've gathered so far, typically parents are preparing for those summer months and really finding their footing during this time and able to engage in more services. Early intervention annual activities do include focusing on our provider network. So we work to develop a network of providers through the DPH contractual process for the provision of direct behavioral services. However, there are several sort of ongoing initiatives that contribute to the provider network and engagement as well. Those initiatives to include pyramid training by GSU, Project Impact and Autism Navigator training, which we'll speak a little bit more about in the presentation, offered by Marcus Autism Center, as well as we discussed the annual MCHAT training and Positive Behavior Support Parent Academy, which is also led and facilitated by GSU, Georgia State University. Service implementation, children who receive an ASD diagnosis are referred for behavioral intervention. As we mentioned, they have the opportunity to work with one of our BCBAs. And there's also an initiative in collaboration with Emory Autism Center where we work on BCBA training and supervision. This initiative derived from the very beginning of the Autism Initiative, where we also saw, as many practitioners in this field have noticed, that prior to the Medicaid benefit being in place, there was a lack of BCBAs across the state. So really, the amount of providers just couldn't meet the demand for children. And we knew that part of that assessment or part of that certification did include training and supervision. So we partnered with the Emory Autism Center to offer that training and supervision. And through that initiative, we're actually able to see some children at a reduced rate. And then we're, of course, able to train and supervise more practitioners that are entering the field each and every day. So our success rate when BCBAs go to sit for their exam is very high. So we're very excited about that initiative. So just wanted to touch in a bit more detail on some of our initiatives that focus on identification of red flags for autism, such as the Autism Navigator Jumpstart to Coaching. The Autism Navigator is a self-paced online resource guide on autism and supportive practices. It provides access to 4 guidebooks that educate on topics such as social communication milestones or how autism impacts development, as well as collaborating to make early identification work for families or coaches. Also looks at getting started with early intervention right away. So again, understanding that the sooner we can identify concern, the sooner we can get started with early intervention and the better the child's outcome will be. And then addressing challenging behaviors. So providers have access to 2 video libraries, the Library of Change with Intervention, as well as everyday activities that they can use with children and families. Project Impact is one of our newer initiatives within the program where we partner with Marcus Autism Center. Project Impact is a parent coaching program for children with social communication delays. So not all children or providers with children on their caseload have to have a diagnosis to participate in this initiative. It's really just primarily focusing on addressing some of those symptoms of ASD, such as social communication delays. Project Impact does provide education through access to roadmaps for helping families engage children, and then teach skills, guidance on how to use family-centered strategies that build on each other, as well as support for responding to common coaching challenges like educating family practice and adapting to family resources and values. Also looks at workbooks or offers and provides access to workbooks for both families and providers and online video resources. So currently, many of our districts are participating in Project Impact and learning about how to support families with children that have those social communication delays. Another initiative that we wanted to highlight today is our Youth Project Initiative or Transition to Adulthood, where we again partner with Emory Autism Center. Dr. Matt Siegel is also the PI for this project, where the Individualized Transition to Adulthood plan is an interactive model that supports adolescents and youth and young adults with ASD who are experiencing school system and transition into youth who are exiting the school system and transition into interdependent life with a continuum of support for positive life outcomes. This initiative does provide access to education and supports with services needed in adulthood, such as post-secondary education, healthcare transitioning, vocational training, housing, and family support. So before we look at some of our most frequently used resources, just wanted to highlight a list of our internal and external partners. This is not an exhaustive list by any means, but we do want to highlight these partners because none of the work that we've been able to accomplish and complete could be done without them. Many of them I've mentioned throughout the presentation, but again, internally, really highly reliant on our Part C program, and externally, many of the partners that we've mentioned here. And just wanted to highlight a few of the resources, again, that we either distribute frequently to our 18 public health districts. One being the MChat screening, of course. We know there is an online version where that can be completed. And then this tool is also translated in many, many different languages. So we like for our providers to know that, and it helps us and supports us with some of those health equity challenges. Also, a link to the Parent Academy, which we highlighted a bit in today's presentation, but that academy does offer caregivers an individualized training that addresses persistent and challenging behaviors for children 3 to 5. And that is offered approximately in 5 cohorts annually. And one of those cohorts is in Spanish. And then again, a link to our transition program, which we highlighted today. And that concludes my presentation. Again, thank you guys so much for your time and attention and for the opportunity to share about the Georgia Autism Initiative. And I will pause for any questions.
I'd like to ask a question. So what is the first step we should do as a child psychiatrist once we diagnose a patient with autism?
I would say accessing the See First referral form and helping or completing that for a family and getting that referral form to the appropriate district. I know it's very tiny here, but you can access this form via our website, but
Okay.
just completing this form, it can be sent via fax or email directly to that district. And then one of our local coordinators within that district will take it from there. So they will begin meeting with the family, contacting the family. And many times the service coordinator is the provider that helps with the wraparound services. So if a child or family is receiving services from multiple providers, the service coordinator is aware, and they are usually the ones that complete an initial assessment with the family, including the MChat, to determine if there are speech concerns, occupational concerns, so on and so forth. I would say that will be the first step.
Okay, thank you.
Welcome. Thank you for your question. Any other questions? Okay.
Well, thank you, Sunita. This was very, very helpful, and it's always. I mean, I know there's services being had, and my observation has been that sometimes I know there's services, but it's sometimes hard to know how best to access those services. So I think that clarifies that a little bit. So thank you.
Thank you.
Any other questions? Okay. Well, let's let Ms. Malia go next. She's been patiently waiting.
Hi, everybody. I am Maliha Haider-Bardil. I am the Autism Project Manager in DBHDD's Office of Transitions. I'm joined today by a colleague and in my department, and I'll let them kind of go ahead and introduce herself, and we can get started with our presentation.
Hello, everyone. I'm Wendy White-Tygreen, and I was tapped by the team in-house to provide some global overview related to autism, and then Malia's gonna pick the second half of these slides as we present. We also have other team members on the phone to answer any questions or complete the picture if we need them to step in. So I thank the entire team at the department for that. We're so glad to be here with you this evening. And so we're going to hit these key points today in the agenda. And a lot of this, I think, is helpful. We're going to spend a lot of time on overview and role because there's often like some confusion and lack of clarity on role and where to turn at which points and stages of different times during treatment needs. So we're going to spend a little bit of time with that. So I think part of the journey, like Sunita was talking, and she and I, we had a lot of sweat equity together when the state made a decision in the mid-teens, just the mid-teens of 2000, to begin its real aggressive and assertive work on building autism services. And so when I think about and I say thank you for the story from the physician and father who presented at the beginning of our time together, as well as Dr. Constantino, who's now joined CHOA. We are in our infancy in Georgia, and I still would say we're in developmental stages in building our capacity related to autism services. I will say the impetus for that in Georgia was this 2014 memo from the Federal Centers for Medicare and Medicaid Services, which said to states, if you have limited autism benefits, that really isn't in keeping with what is defined for EPSDT. And that's early screening. It's I always get early prevention, screening, diagnostic, and treatment, EPSDT. Y'all have kept me late now. And the charge of EPSDT is to have a comprehensive benefit. So this memo was released to all states in the union. It wasn't a Georgia specific document, but it really kind of set the call for the state to begin its assertive planning for what would emerge as a Medicaid benefit for young people in the state. So that resulted then in a subsequent appropriation. And so we are grateful to the legislature and the governor's office and the governor's office of planning and budget for really then beginning the work that was necessary for us, our agencies. And I will say Department of Public Health is here. I'm representing DBHTD today, and our partner, the Department of Community Health, who I think will be joining you at some future time. They began the financing and funding of our agencies to begin rolling out services. And you note that this is an FY 2018 budget. So from that memo to clarity to planning and considerations, it took a few years. So again, these services are quite young in the state. So the state agency partnership that was pulled together by the governor's team at the time was the Georgia Department of Community Health being in the lead role, with DBHTD and the Department of Public Health being tightly coordinated sister agencies in the implementation of the products that Sunita was just talking about, that I'm talking about, and then I hope Medicaid will also continue to speak with you about. And then the Division of Children and Family Services, as well as the Governor's Office of Planning and Budget, were ancillary partners who met with us on a regular basis as well, to be sure that we were considering the needs of young people who were in the care and custody of the state, as well as the Governor's Office of Planning and Budget needing to activate financing, funding, and policy to support our body of work. So this is literally what emerged from that process. And I think this is helpful sometimes to understand and comprehend as we think about the services benefit, how to access it, who to talk to in certain situations, because I think we're all kind of hearing through this discourse that there are opportunities for still growth, and particularly in access in the provider network as we continue to grow the benefit for individuals in Georgia. So the game plan was like for families and young people to have access to everything that you see here in circles from that door over through the right of the screen. And so really, as we move through design phases and decisions were made from OPB about what to fund and where, all of the content that you see, which says Medicaid state plan service, over the blue and gray boxes, emerged as content and items that the state believes should be available to any young people with autism, but the gray kind of being the core focus. But we also knew that there were youth with very complex presentations clinically and some complicating healthcare factors that also meant that we would need the competencies and the service access to also the blue content, which would be still kind of the same modality of delivery. So behavioral therapies or behavior therapies, but when you need them in an intense way, you might need them, for instance, like daily. And you might need that, for instance, in two of the things that are kind of represented here, like, for instance, the Marcus Autism Center has an intensive day program, and they enrolled in the Medicaid plan. And of course, the PRTFs who were referenced before, a PRTF benefit was created by the Medicaid agency, which is very unique. DBHTD administers and helps assist DCH in the administration of psychiatric PRTFs, but the autism PRTF benefit is administered by DCH under this top area that would be ASD behavior therapies, kind of intensive. So all of that content in the blue and gray with the bracket at the top really belongs under the auspices of the Medicaid program with oversight and accountability. And you see the nod to DPH here, and they are doing a lot of the services design that they were talking about just a moment ago through some of these billing mechanisms and those parameters that were set forth here. And then there was a sense that I think is underscored at this point, that there are a need for crisis services. And so because the Department of Behavioral Health and Developmental Disabilities has a history and an infrastructure of providing some crisis capacity to the system, the budget identified that DBHTD would take some responsibility for providing 3 types of service: mobile crisis capacity, ASD crisis support homes, and ASD CSU, So a couple of things for note here. These services are not in the Medicaid benefit. And so they are not classified as like an entitlement or open access. The amount of money that was appropriated was all that was given, and it was all that was promised. So for instance, when the Medicaid budget, when utilization increases, Medicaid, the legislature, the governor's office, through appropriations, considers growth in the gray and the blue. In this green area, the original appropriations is all that has been given to our department. So there was a little bit of money added to our mobile crisis capacity so that our vendors could hire some specialized individuals who have unique training, such as being a BCBA or an RBT. For the ASD crisis support homes, we got funding for a total of 6 beds, so 2 homes, and I'll talk about that in just a moment. And then the ASD CSU is just 10 beds, and it is just in the metropolitan Atlanta area, because that was where the majority of the population volume, of course, resides. And in placing a single autism CSU, we had to then be prudent in the choice of a vendor and a place for that autism CSU to be. So for our department then, again, it was like a limited bucket of resources, which we got implemented pretty quickly. You see here by 2019, we had both of our ASD crisis support homes for youth with autism opened and activated. The ASD CSU required a full build from scratch, from buying the land and clearing the land. So it opened in December 2020. That was a very difficult time, as we all can note now looking back. And then the mobile crisis capacity, we were able to award that with some immediacy because we already had a product, mobile crisis, that was statewide, that was funded with mental health and limited IDD funds, but the ability to just add then some autism support funds into those products and change the requirements to be sure that there was some capacity for RBTs being hired, some current staff being trained as RBTs, and adding BCBAs as responding clinicians for mobile crisis. That was managed, procured, awarded in 2018. So right here, then you see kind of the gamut of not just the 3 services in the lighter green color here, but we also adapted and modified a standing product we had within DBHDD under the Division of Intellectual and Developmental Disabilities. We had this product in the slightly darker green called Intensive In-Home Intervention. And so we adapted and modified that so that where possible, a young person did not have to leave his or her home in order to receive some stabilization. So we really believed in that child-centeredness and that family-centeredness. We weren't given additional funds for that. It was just important for us to kind of round out this crisis package in a way that felt philosophically engaging for families and meeting them where they're at. Again, unfortunately, most of this, of course, it was limited to the small appropriation we received. So you heard me already talk a little bit about the mobile crisis bullets. Intensive in-home, it's time limited, it's community-based behavioral health, behavioral intervention. And it is typically accessed through referral from mobile crisis, the ASD beds, again, short-term out-of-home behavior intervention, again, typically accessed through a mobile crisis assessment and intervention. And then our ASD crisis stabilization unit, which is short-term, it is highly specialized with behavioral staff, and they also do medical stabilization. Again, typically accessed through referral from that mobile crisis vendor, although that's not required for that item. And stay tuned, Malia is going to spend a little bit more time on this in a moment. So, so hang in there with us. So I do want to go ahead and talk a little bit about our mobile crisis capacity. And so I'm not sure how many of you have been participating in some other system meetings across BRIC, but we've done a presentation a couple of times on the emergence of what is now known as 988, which is our call center. And so historically, the Georgia Crisis and Access Line has been doing call center work for our state since 2006. And so we have been fortunate to have an infrastructure of 24-hour call capacity there. And then federal law emerged in 2020, which has now moved us to an implementation just about 2 months ago now, where there is a national easy to call number, 988, and it will connect with the Georgia Crisis and Access Line team members 24 hours a day, 7 days a week. And it rolls over to the national call center if there's any kind of delay or bottlenecking that happens then locally. But mobile crisis is connected then to that 988 function. And so in calling that, there is some immediate screening and triage and assessment telephonically. And then referral can be made to the mobile crisis teams 24 hours a day, 7 days a week. And the response population for Georgia is behavioral health, which is mental health and substance use disorders, intellectual developmental disabilities, and or autism spectrum disorder. So we can respond depending kind of on the type of call, sometimes with targeted practitioners, or I mean, if we're thin and there's a lot of deployments at the same time, you still get a highly skilled clinician and another responding partner. But again, when we can know it's autism, we try to deploy a BCBA and or RBTs to the site to help support the youth and the family. So again, mobile crisis response, what is that locally? What does that feel like? What is it comprised of? You see basically the sub elements of that intervention are represented here on the screen. I think it's important to note, not only does it do kind of that early assessment, it really also deploys de-escalation techniques right there in the moment, helps the family get educated with immediacy about what might come next, and does referral and post-crisis follow-up. So with that, I am going to go ahead and kick it over to Malia for the next few slides, and then I will talk to you one more time before we are able to wrap our part of the conversation.
Thanks so much, Wendy. So like she was saying, once a mobile crisis team has come out and completed their assessments, one of the services they can recommend is intensive in-home. Again, as Wendy mentioned, the service is not exclusively for youth with ASD, but it has been proven to be successful for many of those young individuals. So intensive in-home services are designed to allow an individual to remain in their community, in their home, while still receiving the intensive supports that they need. The services are intended to last for 7 days. They can be extended if behaviorally necessary. And there are clinicians on staff that assess the needs of the individuals as well as their support system around them to determine what services they need. Those kind of services could be access to professionals to assess additional needs and resources, implementations of any existing behavior support plans, caregiver training on those support plans, consultations with any existing services. If a child, for instance, already has an ABA provider, they will link with that therapist, and they can coordinate service from there. And then referrals to additional community-based services that the individual and the family might need. We also operate 2 autism spectrum disorder crisis support homes. They are located in Kathleen and Jonesboro, which are Houston and Clayton counties. They're operated by our in community. There are 3 beds available in each home for 6 total throughout the state, and they serve youth with ASD from 10 to 17 years. So the core team of those homes, there's a program manager, a board certified behavior analyst, a registered nurse, and a case manager. And the homes themselves are staffed 24/7 with a licensed practical nurse and a registered behavioral tech and or direct support professional. This program is designed to last for 30 days or until their behavioral goals are met. So once an individual has been assessed to meet eligibility criteria for the ASD CSH, the BCBA on staff will assess, conduct their assessments and get to the core of the functions of their behaviors. And from there, create an individualized behavior support plan for that child or adolescent. A really crucial component of this program is caregiver training. So there must be a guardian present that's willing and able to participate in that training. The family can come, whether it's parents, siblings can be included. They can come to the home and participate in those training sessions. They also do some via kind of telehealth services, but this in-person family training component is key. The crisis support home also provides case management services. So once we kind of one of our overarching themes is discharge planning begins at admission. So we want not only the stay at the crisis home to be successful, but we need a successful transition back into their community. So we can't do that without linkaging to community resources. And that is one of the services that this support home provides. There are some exclusionary criteria for the home due to the nature of kind of how it was set up. We cannot provide any psychiatric stabilization that includes medical management, any kind of medical change, medicine changes cannot be handled in the home. We have in the past partnered with Laurel Heights to kind of do a coordination of services. So that is an option, but again, we can't we don't have a physician on staff. We don't have a RN 24/7. So we cannot provide those kind of services in the home. And also, since these homes cannot be locked, the individual must meet the elopement assessment criteria that was developed by the provider. So if there's a youth in crisis, and if they do meet that exclusionary criteria, they could be eligible for our ASD crisis stabilization unit. This unit is currently operated by Viewpoint Health and is located in Rockdale County. The CSU serves youth with ASD from 10 to 14, and they may be duly diagnosed. They may have comorbid behavioral health conditions. And the services that they provide include crisis-related needs assessments. That could be a functional behavior assessment, kind of assessing what their support needs for their activities of daily living could be, medical, nursing, nutrition, a gamut of various supports are available. They also provide therapeutic services for behavioral and psychiatric stabilization, and caregiver training is also a very important component for this unit. And I'll throw it back to you now, Wendy.
Sure. So we think, one of the things that's kind of important to denote as well is when we're thinking about young people with ASD, and this is like a question we end up fielding all the time, which is why we crafted a slide around it, is, youth in Georgia who are Medicaid covered, they fall kind of into two buckets, right? CMO covered foster care, which is at this kind of top of this bracket under the Medicaid eligibility header. Excuse me, I was going to click on it and highlight it, but it advanced the slide. Sorry. And then the fee-for-service designation category, which means they are not in a care management organization coverage. They are not in a managed care product. And so they're what's considered to be in the fee-for-service reimbursement model for the state. But when we are doing planning for young people, again, we're coming in this space of crisis, right? But we think this is kind of important for kind of all players to understand, is we're looking exactly for what we heard earlier in our presentations today, which is, one, what is activated from the school systems, kind of what supports are wrapped around young people where they are. Which for the majority of the day is in the school system. What reinforcements, what parts of those plans should be activated? And then, of course, Medicaid services are in the Medicaid state plan. And you saw all the gray and the blue circles, right, under the purview of DCH's authority. And so there are assessment services and screening services which are activated through pediatricians. There's some coordination services activated through those pediatricians. There are all the assessment functions that are in that general medical plan. There's the whole array of autism services, which we saw in the blue and the yellow circles. They have codes that go with them and names that we'll let the Medicaid agency talk to you about for sure. And then there is a recent plan by the Medicaid agency to approve a behavioral aid service. And that service right now has been submitted by Georgia to federal CMS, the Centers for Medicare and Medicaid Services, asking for permission to move that ahead in Georgia, which is a standard process that always has to occur in those negotiations between state Medicaid agencies and the federal government. So we are hopeful that that is also right around the corner for individuals who may have an ASD condition. And I'll just denote at the top of both of those columns that I just talked about, these are entitlement benefits. So they're like just supposed to be available, right? And we know, like I talked about, right, developmentally, we are in our program's infancy. And I say we because it was a collaboration of multiple agencies, but the state is in a very early developmental stage right now for these services and benefits. And then the department has comp and now waivers, and those are payer of last resort models, and they are limited, they have limited enrollees. So the state, for instance, has to submit to the federal government the numbers of individuals for whom it believes it is funded enough to serve in a particular scope of time. And so when folks earlier were talking about more waivers would be great, we agree. And it just makes it extraordinarily difficult with thousands of individuals who have been waiting for many years, as was earlier referenced, that it makes it very difficult to create access through now and comp, which is why we so heavily press, comprehensive access to Medicaid state plan services and school-based IDEA services where they can be made available to the young person. So that concludes our presentation. And I went ahead, Aaliyah, while you were talking, Dr. McGibney put the question in the box about capacity for the crisis support homes. And so I went ahead and addressed that. Again, just underscoring again what's on the slides, which there are 2 homes with 3 beds each. And that was all that was funded by the legislature.
Yes, thank you for taking care of that, Wendy.
Sure.
Thank you.
The one other thing I'll just go ahead and add that I think is also helpful is the comment was made earlier about the age brackets, and Malia hit on those. When we were funded for such limited capacity, we embarked on some research about where, for whom does crisis occur most often when there's an ASD condition, and began to look at the research and the data for that to kind of begin honing our scope. And then we began to think, okay, well, for safety purposes and, in terms of like somebody being like a 17 or 18-year-old who's a really big person and really heavy in a facility with a 5 or 6-year-old, kind of what needed to be our sweet spot with those very limited bed count numbers. And so that age bracket is set there a little narrowly in order for us to try to be sure the health and the safety of the entirety of the young people who may be present in that milieu. So just wanted to share that as a response to kind of some of that dialogue from earlier.
Thank you, Wendy. It's very eye-opening. I want to ask a question. Is there a mechanism going forward to expand both the crisis stabilization units and make them more statewide, and even the crisis support homes?
Right now, there is not, there's dialogue about expanding crisis stabilization units, but because of the 988 implementation, those are focused on mental health and substance use conditions. So there's a lot of dialogue about that, but there has not been any recent dialogue about expanding that capacity related to young people with autism conditions specifically.
Because I don't think I need to tell you that 6 crisis stabilization beds for a population of the state of Georgia and I wrote down how many, I guess 10 for the crisis. So that's not so much.
We feel that as well.
Okay.
Well, thank you for saying that, because I appreciate your presentation and it cleared up some things, but like you said, you focused on your infancy, and I get that, but people are desperate and they're waiting. And I know you can't help that. I mean, you can't create money out of nowhere. I mean, it has to be legislated, but like he just said, I mean, 10 beds for autism, crisis stabilization, and 6 crisis beds. It's just, I mean, that isn't even scratched the surface. It's good for a model of this is what we're going to do, this is how we're going to expand, but it's more of like this is just a show on paper that we're doing something, but it's not accomplishing very much.
A developmental stage is not meant to be stayed in. So yes, and it's what I recognize and just want to honor is, I'm also a parent, and so it is just a challenge to think about access being contained as it is right now. So I just really want to honor the journey you shared and understand we've talked to families everywhere who are very hopeful that this benefit has been created, and they live in hope that it will grow.
Well, I'll let anyone else who has questions, but I know the hour is late, and I really do appreciate the quality of these presentations, and we certainly achieved our goal of identifying what the issues are and seeing what the current services are and where we need to move going forward, I think. And I think it's extremely helpful. And again, I appreciate you for sticking around, because I think it's enlightened a lot of Dr. Constantino. I'm sure this was helpful for you as well.
Oh, it was extraordinary. And I think, Wendy, your presentation about the evolution and the timing of things, and let's all hope that there's going to be a rapid continued growth and evolution. I do think that it's important for everyone to understand that when one invokes the notion of a unit for the concentrated care of a person in crisis, one of the things that happens is a multidisciplinary effort to stabilize them, to think about what's going on at home, what is going on in their school environment, in their work environment. Where can we get some traction with, medication changes? Where can we use an appropriate behavior support plan, functional communication training, and a great, stabilization program syndicates the convergent knowledge of all the cards that we have to play for a patient in crisis. And that, and that can be a physical facility, and often needs to be to keep a person safe under the circumstances. But I also want to just offer some hope that even as we're expanding those kinds of services, collectively trying to figure out how best to do that, it's also possible to converge those sources of knowledge around patients before it gets to that, But oftentimes those aspects of knowledge and expertise are horribly siloed. And you know, a kid with an impending behavioral crisis will get one service that's needed, but not the other. They're because the services are organized by bureaucracy rather than a person-centered kind of approach. And so I would really urge everyone to always be thinking about, before the crisis, the same principle applies. If we can weave together the different offerings of different disciplines to solve a problem, to think about, you know, how a condition can be stabilized, even in the outpatient realm prior to that, it's a very important tool that we don't want to just dismiss, that we don't have a play at. And so, you know, I will definitely look forward to working with everyone in the ongoing evolution of this process, both on the, you know, on the side of the you know, residential care and the stabilization of kids who are just absolutely, there's no other way to go, but to try to get to the front door of that, and also to the back door of that we're engaging outpatient, you know, kind of teams that can be responding to needs before they get that acute, and then also stepping down after those stable, because I think all of us have seen patients that go into these stabilization situations get discharged, and then the wheels fall off because the whole package just isn't there. And so we'll really look forward to working with everybody, and really appreciate all of this work, all the presentations about what's going on.
Dr. Constantina, I think it's a helpful thing. And again, this is not, the blue and the gray is not DBHDD's benefit, but like Sunita and myself, we sat at the table advising. And one of the things that we built into, you know, our expectations of our sister agency at Medicaid was that all of these services would be reimbursed at a higher rate to be done in home.
Yeah.
So if you're in a clinic and you're getting one of these services, you get one rate. But if you get, if you ever are in somebody's home, you make more money to help cover the cost of really being engaged.
Yeah.
Because environment matters.
Yes.
And home matters and family matters. And you'll hear that from the DBHDD team more times than you'll blink in a day. That is just crucial. And so we did advocate that, and that was part of the benefit design. And so I hope, remember, I just want to say one more time, just understand that DCH, I think I heard through some of the dialogue, will come at some point soon and talk to this team as well. And I know Bhavini had to leave. She's one of their vendors who I partner with quite a bit on several policy and planning functions. But again, I think all of these things here, the more aggressive we can be early and often. Thinking about your slide about the functional impacts, positive functional impacts for young people when a service can be provided and provided consistently, that's where we want to be.
Right.
We don't want to be in this crisis mode, right? We want to be in the blue and the gray, early intervention, often in home as often as possible, in their community for sure. And using the green circles sparingly. We want them to be there, but we hope that they can be used less and less as more of this other capacity really is refined, emerged, and there's access for that.
Yeah, I mean, I think in-home support strategies can have a magic all their own and have really rescued many patients and families. Sometimes they fail, sometimes they are absolutely the essential ingredient, that's what turns a situation from not viable to sustainable and a pathway to recovery. So I really appreciate that. I think though it's sometimes instructive also to think, let's just say very concretely, in Georgia, if a kid with autism needs a medication and a positive behavior support plan and a specific kind of let's just say a developmental therapy or a specific therapy specific to their condition. Usually, the question is, can they get all those things, from the same function? Or do they have to go, all three, separate kind of sources for that care? Or if it's a, social environmental support, do they have to go to 3 different places to get that? Because the more often that kind of fragmentation in a plan occurs, the less likely it is for the whole plan to materialize. And then it's going to be a requirement for inpatient or, an in-home support strategy or a crisis stabilization. So there's structure to this too. And I think if there can be ways to dovetail the different components of care that can rescue, these kind of situations early, I think it's really important.
I think I share this sentiment with many of us on this call that we're really happy that you decided to move to Georgia. The question is, can we get you to become a Braves fan anytime soon?
That will not happen. I'm sorry. I will declare that. The important thing for me to do early is I express hope, but actually I have to set expectations, set some boundaries, and that's one.
Thank you so much, everyone. This has been wonderful.
Thanks for the invitation. Thank you all.
You're very welcome. All right, bye-bye.